talk as well. So it's my pleasure to welcome Dr. Ala Shaikhkhalil. Dr. Shaikhkhalil is an attending pediatric gastroenterologist and nutrition specialist in Nationwide Children's, and she's an assistant professor of clinical pediatrics at Ohio State University. She's going to talk to us about GI nutritional outcomes with CFTR modulators. Ala.
Hello, everyone. Thank you so much for the kind introduction, and thank you so much for inviting me to this great conference. So I'm going to be talking today about gastroenterology and nutrition in the era of CFTR modulation. So I'm going to start with just a brief case discussion to tie in everything together. So I have this CF patient who just turned 6 years old, whom I've known for most of his life. These are his mutations as shown on the screen. In addition to multiple GI manifestations that he's had, he started presenting with these severe abdominal pain episodes with small bowel to small bowel intussusception. And really due to his GI issues, he has spent probably the last 6 months out of the last 2 years in the hospital. So as part of his investigations to try and figure out why this was happening, we did a video capsule endoscopy where endoscopically we placed this capsule that takes multiple pictures throughout the length of the GI tract. And what you can see for my friend here is these really thick strands of mucus that almost completely obstruct the lumen. And just for reference, this is what a normal video capsule endoscopy looks like. So I just wanted to show you this to kind of tie in why the GI tract is really important in cystic fibrosis, both for clinical outcomes and for quality of life as well. So here's what we're going to talk about. We are going to highlight some nutrition-related and GI outcomes in CF. We are going to talk briefly about what are the goals of nutrition management, what are the importance of that, and then how do you approach malnutrition in CF? And then I'm going to touch on CFTR modulators. Why is it important to study GI outcomes with this therapy? And what are the GI outcomes with this therapy? So as you know, of course, CF is a disease of epithelial lined tubes. So just like the lungs, the pancreas, liver, and the intestinal tract is epithelial lined. So it starts with the epithelium and then it goes into the parenchyma. And that's why the GI manifestations of cystic fibrosis, as you know, and as shown on this figure here, span essentially the entire length of the GI tract, starting from gastroesophageal reflux, ending with rectal prolapse, and really everything in between. And the same vicious cycle that you see in the lungs that starts with obstruction from thick dehydrated mucus that adheres to the lining and causes inflammation and secondary infection is essentially very, very similar to what happens in the GI tract as well. And it's very important to know that the GI involvement in CF goes well beyond the pancreas, and to remember that CFTR is heavily expressed in the GI tract. And just a brief primer here, a reminder of physiology. This here is your proximal duodenum. After you eat food, the stomach acid and the chyme that's associated with that will come into the proximal duodenum. That's going to trigger production of secretin, which will in turn produce bicarbonate into the proximal duodenum. This step is extremely important in neutralizing stomach acid, increasing pH in the proximal duodenum, which will allow function of pancreatic enzymes and formation of micelles. And guess what? This step is CFTR dependent, at least in part. So reminder, it's beyond the pancreas, and CFTR not only heavily expressed in the GI tract, but functions there as a bicarbonate channel. So that all will shed lights on this concept of the CF gut and why it's happening and the complexity of the pathophysiology there. So we're starting with dehydrated, acidic luminal secretions, acidic because of the lack of bicarbonate, malabsorption that is very much multifactorial, but hinges on problems with pancreas and biliary secretions, and then the chronic inflammation. So you add to that these impaired pancreatic biliary function and the viscous mucus that adheres to the epithelium and creates this very thick layer all of that ends up explaining these GI manifestations that we have, including pancreatic insufficiency, cholestasis, steatosis, poor micelle absorption, and then at the bottom of the slide, what I think is some of the most important GI manifestations with dysbiosis, small bowel bacterial overgrowth, impairment of motility, and impairment in IgA secretion as well. So when we talk about GI and nutrition management, what are our goals here? So this is something that we all know. We want to promote for children growth and development, for adults maintaining a healthy nutrition status. We want to enable to have high energy intake, achieve sufficient fat-soluble vitamin and essential fatty acid status, and in addition to that, improve symptoms of diarrhea, abdominal pain, and bloating. This is a slide that I'm sure you have seen before, and I'm going to orient you to it real quickly. These are US-based data from the Cystic Fibrosis Foundation. This is the most recent one we have from 2018. On the x-axis here, you have the BMI percentile. This is for children. And then on the y-axis, you have the FEV1% predicted. And as you can see here from the line, right at the 50th percentile is when you see some clear separation in lung outcomes with dramatic changes for people whose BMI is above the 50th percentile. Same thing for adults. So based on these data, the Cystic Fibrosis Foundation published these goals for nutrition management, and they are very similar to the ones published also by the European CF Foundation. So what do we have in terms of interventions that we can maybe use to help for people with CF? So we know that we can boost the calories, we can use behavioral therapy, we can use medications that can help promote appetite, and then we can also use enteral tube feeding. Those are the nutrition interventions that are available to us as of now, of course, with the recent addition of the modulators. But what do you do when they're not working, right? So you have somebody who is on pancreatic enzyme replacement therapy and for whom you have tried some of the typical approaches to optimizing nutrition. Then what do you do? Okay, so I like to think of it as different buckets. So the first one is there an increased expenditure? Is there a metabolic issue here? What are the lungs doing? Are there exacerbations that are frequent? Is there salt depletion, a zinc deficiency? Is this patient extremely active? Do they have CFRD? Or is this an absorption problem? Is there a reduced adherence to pancreatic enzyme? It's a very common problem we deal with. Could there possibly be a need for acid blockade? I have a question mark next to that because that's controversial. Could there be CF liver disease impairing absorption or some other GI diseases? People with CF can get other GI diseases as well. Or is this a psychosocial problem related to inadequate knowledge, barriers, maladaptive feeding behaviors, or family dysfunction? And then finally, is the patient simply just not getting enough calories? Again, thinking about, is there constipation, iron deficiency, swallowing problems, grazing, or excessive juice intake, especially for toddlers? And this might be an oversimplification, but it just gives you an approach of how to approach the malnutrition. And what I've learned in CF so far is that it's almost never just one thing. It seems to be always multifactorial. However, once you identify some of these things in the bucket, you intervene and you follow up in 2 to 6 weeks, and you repeat that as often as you need to. So onto the CFTR modulators. So these differ fundamentally, right, from established CF therapeutics because they're not working just on symptoms. They aim to increase or potentially restore function of the CFTR variant protein. And when they are highly effective, they can be transformational for those with responsive mutations. So what are the principles of CFTR modulation? As you see here in the graph, you have the CFTR channel at the surface membrane. And these drugs aim either to potentiate, meaning you increase the function, increase the time the given channel is open, or you correct it. You correct the processing and delivery of the CFTR into the cell membrane, or you do correctors or read-through agents. So the sum of all of that is how much improvement you're going to get at the epithelial cell surface. So I have a poll here to the audience. I just want to know if people have used CFTR modulators for their patients, since we have an international audience. So I'd like people to answer this question, yes or no. So the poll is now on their screen. I have treated CF patients with CFTR modulators, yes or no. And then in 15 seconds, we can stop the vote and get the answers. Okay, so far, and I know we probably didn't have enough chance for everyone to respond, but there's a 81% who said no, 22% who said yes. That's one thing that I think is a problem with the CFTR modulators, is their equity and availability globally. So, but we're going to talk about our experiences so far. So we're all familiar with this paper from 2011 when ivacaftor first came out for the G551Z mutation. So what happens with that? And I'm sure you've all seen this slide as well. Here on the x-axis is time, up to 48 weeks. On the y-axis is sweat chlorides in millimoles per liter. And you can see here in the blue is the ivacaftor group, and there's dramatic reduction in sweat chloride compared to placebo. What about lung function? Same thing, dramatic improvement in ivacaftor group compared to placebo. Weight, also dramatic improvements in the ivacaftor group compared to placebo. But what are some of the limitations of this? We know that changes in sweat chloride do not always correlate with clinical outcomes. And we know that FEV1 and lung function can be normal in infants and children. So how do we study the drug outcomes in that group? And we know that weight gain is very important, but it can be multifactorial. So the GI tract, I will argue, offers opportunities to measure CFTR function and systematically evaluate CF-related outcomes for clinical trials. Well, what are those outcomes? What have we known so far? And I would like to start with why study GI outcomes? Why do they matter? And of course, as a gastroenterologist, I'm a bit biased, but I think the GI phenotype is highly relevant. It can be the first manifestation of CF that will come back even before the newborn screening, such as in meconium ileus. It can cause severe complications and severe symptoms and really impact the quality of life. We know from surveys from the CF community that studying GI issues is one of the top 3 priorities for CF patients and their families. And there can be long-term consequences for abnormal or diseased GI phenotypes. Other thing that I think is really exciting is that when the previous speaker has talked about that too, is what we thought to be previously irreversible is maybe changing. And the GI tract will give us an opportunity to evaluate outcomes in young individuals. So what are some of the potential GI endpoints that we can think of? Well, there's of course weight and BMI. The liver offers some outcomes with looking at steatosis, usually via MRI or ultrasound, looking at liver enzymes, bile acid homeostasis. If we're going to evaluate the pancreas, looking at elastase, looking at intestinal pH and transit. Of course, the organoids, very important. Body composition measures are important. Markers of intestinal inflammation, such as fecal calprotectin. And then also the video capsule endoscopy that I discussed for my patient earlier. So lots of opportunities to study the GI tract. Is it perfect? No. there are challenges with studying the GI tract. We don't have an FEV1 for the GI tract. I can't tell you how your GI tract is doing. There are no clear measurable outcomes. And the manifestations don't correlate with recognizable disease and don't always correlate with symptoms either. Some of it might be irreversible as well. And specific therapy remains lacking with very few exceptions. But what does the literature say about CFTR modulators in the GI tract? So I'm going to highlight just a brief overview from some studies. This isn't going to be everything, but this paper by Basanova looking at the US and the UK CF registries with ivacaftor. So this is more of a long-term, what we call real-world data, right? And with that study, they've looked at those on ivacaftor and matched them by age, sex, and CFTR genotype severity. And the GI outcomes here were tracked differently. They were not really called the same thing in the US and the UK, but what you can see here, ivacaftor group in blue and the comparator group in gray, there were less GI, the prevalence of the GI manifestations was less in the ivacaftor group, same for liver. This paper here, I think, is really fascinating, and it's from the Children's Hospital of Philadelphia, and it talks about the energy balance and the mechanisms of weight gain with ivacaftor. So they took people who were on ivacaftor for 3 months from Italy and from North America, and they looked at outcomes such as body composition, total energy expenditure, resting energy expenditure, REE, coefficient of fat absorption, stool calprotectin, and elastase. And these are just some highlights of their results. And I have circles around the outcomes that were interesting. Fat mass increased significantly in the entire group. Resting energy expenditure decreased. So that means that the number of calories that you need to just exist is less after ivacaftor, which might explain, the improved weight gain. Fecal calprotectin, which is a measure of intestinal inflammation, reduced significantly. Elastase increased. However, it only increased in pancreatic sufficient patients in this cohort. So it did not increase significantly for the pancreatic insufficient group. But that's not the same in other studies, and we'll get to that in just a moment. So what I noticed in this study is that there was, of course, more weight gain, more fat-free mass. We know that fat-free mass correlates the best with long-term outcomes. Resting energy expenditure reduced, coefficient of fat absorption improved. And in the graph here in blue, we have the pancreatic insufficient people, and you can see that the improvements were much more dramatic for those who were pancreatic insufficient than those with sufficiency. This is a similar graph depicting the similar concept. So then what are the potential mechanisms of weight gain with ivacaftor based on what we see from this paper? Could be reduced energy expenditure, could be reduced inflammation, whether in the GI tract or systemic inflammation, improved taste and smell due to less inflammation in the sinonasal mucosa, increased appetite, increased bicarbonate, improved fat absorption, and improved mobility or motility of the GI tract. Another really exciting study here from Canada with the impact of CFTR modulation with ivacaftor on gut microbiota and intestinal inflammation. So here they took 16 subjects with ivacaftor and did a 16-month follow-up. And what they found were significant reductions in calprotectin, significant increases in Akkermansia, and decreases in Enterobacteriaceae with decrease in calprotectin. All of these are favorable changes in the microbiome and the intestinal environment. This paper by Dr. Gelfand and group looked at the pH change as a result of CFTR modulation. So remember, we talked about how CFTR is a bicarbonate channel within the GI tract. So what we actually can measure the pH of the GI tract using this little pill here. It's called a SMART pill or wireless motility capsule. People swallow it, and you are able to measure pH, pressure, and motility throughout the GI tract. So what did they find? I'm going to orient you to the graph here. So on the x-axis, you have minutes from gastric emptying. On the y-axis, you have pH. And you want the pH to be optimally at least 5.5 for the pancreatic enzymes to work very well. So before ivacaftor, in the green dots here, it took approximately 40 minutes for CF patients to achieve that pH of 5.5. After ivacaftor, that went down to 8 minutes. So the amount or the length of intestinal mucosa that you don't bypass in this is extremely important. And 8 minutes is very, very similar to healthy controls. So very exciting data, and again, goes to the function of CFTR as a bicarbonate channel. So if we improve GI outcomes, we could possibly prevent or treat pancreatic insufficiency. If we decrease the pancreatic damage, we could possibly prevent CF-related diabetes, because we know from newborn data that those with a lower IRT, with a higher IRT have less pancreatic damage and less chance of having CF-related diabetes. This paper here, the Arrival study, these are for young children, right, aged 12 to less than 24 months of using ivacaftor, and you can see the steady increase in fecal elastase, and for some subjects were below normal to ones that were robust. So again, we talked about potentially preventing and treating pancreatic insufficiency or CFRD, treating fat malabsorption, intestinal inflammation, restoring intestinal bile metabolism. What does that do to intestinal malignancies? We know that people with CF unfortunately have a higher risk of different malignancies in the GI tract, and then maybe improve symptoms. My friend from the case discussion earlier is going to start elexacaftor, tezacaftor, ivacaftor soon, and I'm very, very excited to see if that's going to help him. What else? What's next? Of course, elexacaftor, tezacaftor, ivacaftor is the newest drug that was approved by the FDA in the United States approximately a year ago. Has been one of the most exciting developments in the CF world so far. And what we're seeing here is, again, very similar but dramatic improvements in BMI. So x-axis, you have time, the y-axis, you have BMI, huge difference between the people on triple therapy compared to placebo. But there are some problems.
Two minutes, Ella, so that we can wrap.
Okay, 2 minutes. I am good to go. Just some issues that still persist. We still have linear growth deficits. We haven't been able to fix those. We still have deficits in body composition, and we don't have enough data on how CFTR modulation will change body composition. We don't know about obesity, at least in the United States. Up to 30% of patients with CF in some centers are either overweight or obese. What's that going to do to our CF patients? We don't know yet. And as you know, the PROMISE study is actually really going to look at GI outcomes very, very closely. And those are some of the outcomes that they are already looking at, and hopefully we'll learn more about soon: intestinal pH in transit, liver disease, pancreas in terms of elastase and IRT, dysbiosis, growth and body composition, inflammation, and symptoms. We have some really exciting data about patient-reported outcomes and making those standardized for the GI tract. As you know, there's also been CFTR genotype-based stratification where we're able to get FDA approval of these drugs using in vitro and not just in vivo data, and that increases access for the drug for rare mutations. Is this without controversy? No. So while we know that CFTR modulators are generally very well tolerated, we know that they have adverse effects, and those can be in the respiratory tract, GI, or liver. Cost is very high, and it's a lifelong type of medication. Insurance coverage is an issue, especially in the United States, but then international availability and equity is also a problem for CF patients globally. So I'd like to end by just highlighting that optimizing nutrition correlates with improved survival and clinical outcomes. And a thoughtful approach to apparent failure in nutrition management is very important, and that understanding CFTR in the GI tract can be a key to therapeutic development, and that nutrition and GI outcomes can be important, exciting endpoints for CFTR modulators and other CF-related research. thank you very much. And if there are any questions, I'm happy to answer those.
Thanks very much, Hala, for an excellent talk and the importance of nutrition and the modulator role as well. Couple of questions. Is BMI the best measure to go by when we're assessing nutritional status?
That's a very good question. BMI has its own limitations because it's not really a good predictor of body composition. And we know from some research that it does not always correlate with fat-free mass or predict fat mass. But it really is the one that we have that's easiest to obtain for almost everybody. So we use it. But I think in the future, using more precise indices of body composition, such as fat-free or lean mass, is going to be more important to look at for our patients.
And another question, which is very practical, in the absence of diagnostics in stool elastase in resource-limited areas, am I justified to start the child on enzyme replacement therapy if there is growth faltering?
Absolutely, yes. We were having this conversation, Dr. Basil, not too long ago. Pancreatic insufficiency is a clinical diagnosis. So the elastase is a nice tool. It's helpful for you to have. But if you're clinically suspicious of pancreatic insufficiency and you treat it and patient improves, there's your diagnosis. The patient is pancreatic insufficient. So yes, absolutely justified in giving pancreatic enzymes.
So that might be a message from us to, in areas where there is lack of diagnostics, sweat tests, stool elastase, etc., that if nutrition is faltering, one might go with that.
Thank you, Ala. I promised the previous one from the previous session that you will answer this question. Okay. What about the modulator? He said there are some reports of patients with significant liver side effect after the CFTR modulators. What do you think? Is it real?
There are some, it's a very small number of patients, but there are a subset of patients that seem to have severe elevation in liver enzymes with use of modulators. To my knowledge, there are no cases of liver failure or cirrhosis related to that, but the liver enzymes can be significantly elevated such that we've had to stop the treatment for some people. What does that mean in the long term? We don't know yet. I think that if we think about the pathology or pathophysiology of CF liver disease, it would make sense that the modulators actually ultimately help the liver because they will restore CFTR function there. But we don't know the answer to that in the long term. And yes, there are some patients who will have a significant elevation of the liver enzymes and will need to have the drug interrupted or stopped completely.
Thank you, Anna. Thank you.
Yeah, absolutely.
I think we should end this session here. Again, Dan, thank you very much, Hala, for an excellent talk. And thank you for being able to join us there. Thank you.
Thank you so much for the invitation. I appreciate it. Bye-bye.